still on time, and we're now going to move on to the next talk, which is about cardiothoracic transplantation. We're delighted to have Mr. Harikrishna Doshi speaking to us. He's done his training in a number of units across Scotland and was the National Transplant Fellow for 2 years at Papworth Hospital. He also went on to be to do the Chief Resident Programme at the prestigious Judge Business School in combination with the University of Cambridge. So, Mr. Doshi, looking forward to hearing your talk. We can't hear you yet.
Can you hear me now?
Yes, perfect.
Okay, great. So thank you for the opportunity, and I'm really delighted to join. Coming back to the point that Mr. Kirk was making, I think I did my fellowship. In fact, I did my training here in Scotland, and then I got selected at Papworth for my heart and lung transplant fellowship. And having gone through that fellowship, I am the product of that fellowship, and then had gone to visit Toronto unit as well as a unit in North America. And I can say that our training matches anywhere in other parts of the world. And of course, we lead in some of the areas like DCD heart transplantation, where we are the pioneers, and where majority of the research has actually taken place. And there's no doubt in my mind that if you get trained into some of the best units in the country, you do get the best training, and you can deliver that care. So I'm going to talk about the cardiac transplantation. We've got 6 centers of heart and lung transplant, so to say, which includes Harefield Hospital in London, Papworth Hospital, Cambridge, Birmingham, Newcastle, Manchester, and Glasgow. We offer currently heart transplant. Comparing to the other units, we do less number of transplants, but of course we've got new team in place, and the aspirations are big. And I hope we can meet our aspirations of expanding our numbers as well as expanding the transplant into the other areas apart from the heart. As Mr. Kirk had alluded to the fact, this is where we are based, Golden Jubilee Hospital in Glasgow. And I say that because the size does matter. You know, when you work into a unit, it's important for you to know what sort of unit you're working in, especially in the transplant, the size definitely matters. But in terms of our unit at Glasgow, we are the largest center for Scotland. We do around 1,500 adult cardiac surgeries. We offer adult congenital cardiac surgery, and I'm sure you're going to hear from Mr. Peng soon enough about the congenital cardiac element of this. You have heard the talk on thoracic surgery, and we are the Scottish National Advanced Heart Failure Surgical Unit, which we call as SNAFs. So I'm going to ask you to brace yourself, because I'm going to take you to the journey and going to make you experts into cardiac transplant. And I hope at the end of this ride, you'll be as happy as the people who were a part of this ride. My talk is basically going to be on the current scenario about the transplant, some elements of donor or the donation, some element of the implant, and then I'll talk about the recent advances in the cardiac transplant. The most important element for a cardiac transplant, or for any transplant for that matter, are the donors. Somebody loses life, and that precious gift of that organ saves many. So from one donor, you get 8 solid organs, so essentially 8 lives. And then there are tissue donation, which can help around 75 lives. So it's not just one donor who's giving up or who's lost his life, and that precious gift of that organ and the tissues can help and touch so many lives. And in a way, when we look at the solid organ donation outcomes, so say, for example, heart, at the end of 5 years, roughly 80 out of 100 are still alive. Now, these are young patients who are in their 30s. And so at the end of 5 years, 10 years, we say median survival of 12 to 15 years, which are prime and the most productive years of their life. Um, and that adds value to the family. It adds value to their own lives, and these are the most precious years that they can get out of a transplant. So there's nothing more nobler than giving a gift of the organ. We talk about Scotland. We've got 550 people waiting currently, awaiting an organ transplant, but unfortunate reality is the 10th of them will not make it to the end of 1 year because we don't have enough organs. When we look at the number of transplants, so say 2008 to 18, there's an increase in the number of transplants by almost 70%, but still we can't do enough. The waiting list has tripled. The sickness of this patient is increasing, their heart failure is increasing, and we have to keep them alive using mechanical cardiac supports like ventricular assist devices. And that puts a burden not only onto the healthcare as such, but also complicates the transplant surgery in terms of the outcomes. And so with that current scenario, I'm going to take you to the donation parts. And it's important because you will hear these two terms, DBD and DCD, or donation after brainstem death, which essentially means that a donor is donating their organs, they are brain dead, but heart's beating, and essentially the organ donation takes place. But they are brain dead, so to say. And then you've got donation after circulatory death. And this is an area which is evolving and has taken up a lot of recent research. And I'll come to that a little bit later on. What is the ideal heart donor? It's difficult to find nowadays. You've got young patient, we've got reducing road traffic accident, we've got reducing violence, and all that in a way makes us wonder that is there an ideal heart donor? Someone who doesn't have a chest trauma, someone who doesn't have any episodes of blood pressure drop, someone who's got normal blood pressure, someone who's not on any drugs to support the heart, who's never smoked, who's got normal lifestyle. And thereby, what we increasingly use nowadays are borderline donors. But what happens in a brainstem death is that then they are bombarded with body's own catecholamines, and that surge not only impacts every organ, but it impacts the heart in a big way, and the heart gets a collateral damage. So it's, although the heart seems to be functioning fine, there are issues going on with the brainstem death that causes obtundation of the cardiac function. And so if you look at it, on an average, we've got around 1,500 eligible DBD donors, but we end up taking around 160 or 190 hearts at the end of that. And thereby there are a lot of organs which we don't necessarily use. And if you look at this graph, it just shows you out of every donation, we take around 20 hearts and around 20 to 25 lungs for the actual transplantation. And so the organ utilization is not that great because either we do not have the assessment capability to find out the actual reserves into this organ, and don't know how strong these organs are and whether they'll be able to support the function. I'm going to take you through the retrieval surgery. So when we go for actual retrieval, this is what happens. Now, this is a video which has been made, not necessarily into a retrieval. So there'll be an element whereby this is a part, but this is just to give you the flavor of what actually takes place during a retrieval. So when the retrieval team goes, they open the chest, and then they start assessing the heart, and then they start assessing the lungs. But remember, it's not just these organs. There are 8 organs, or almost 8 recipients across the country who are getting admitted during this time when the retrieval is taking place and the organ is being assessed. That's why, you know, it's a logistical nightmare, as you can imagine, that everything has to fall perfectly. But we do have some wonderful team who helps us in doing so. And as you can see, once they assess the heart, they start assessing the lungs. They make sure that everything is fine. The lungs are expanding fine. You can see some collapsed element of the lung. They ask the anesthetist to bag the lungs, make sure that the lungs fully expanded, and there are no lesions. And once that happens, we know that these organs are good and they are ready to be utilized. And as you can see here, the chest as well as the abdomen, both are open, and the organs are being assessed and being readied. And once the organs are retrieved, then they are transported. We call this as a picnic box, but they're transported either through a road transport or an air transport and handed over in a safe manner in the implanting center, where the recipient is already on the table awaiting. A team awaits the outcome of the assessment, and the patient's ready to go. And essentially, we take the heart out and do the 5 anastomosis. This is a rough diagrammatic representation that what we do is take the heart out of the recipient, and once the new heart arrives, we do the anastomosis at the level of the left atrium, the aorta, pulmonary artery, inferior vena cava, and superior vena cava. And once the 5 anastomoses are done, in a way, the operation or the surgery is complete. 6 hours plus surgery. Technically, it's not a demanding surgery, but what's important is an element of assessment whereby we know that the organ is able to support a new circulation for the heart. And once that happens, if the heart needs some help, then we do have lots of techniques up our sleeves, either pharmacologically supporting the heart, if not mechanically supporting the heart. And the cadre of the mechanical support can escalate from intra-aortic balloon pump to ventricular assist devices. And once the heart looks to be in a good condition, supporting the circulation in a good manner, the patient gets extubated in the intensive care unit after the chest is closed and patient transported back into the ICU. They spend few days into the ICU, into the step-down unit, and essentially go back to the ward where they do the further recovery process. That, in a short, is about the actual retrieval and the implantation. But where do we go from here? Because we need more organs. We need more ways to support these very difficult patients. And one of the way is either in rather than using the picnic box, is there any way whereby we can use something where we can use the patient's own blood and pump it like what happens inside the body, and then we can support the heart for a longer period of time. So rather than a cold storage, a warm functioning environment is provided to the heart. So rather than the average 3 hours of time that the heart can remain ischemic, we try and increase that number so that we can take the heart to a different part of the country. And for places like Scotland, this is very important, because usually when we get the offer, we are sitting almost on the verge of our limit to which we can accept the heart. But if there's any way we can support the heart for a longer period of time, using machines like the organ care system, then it's worth expanding. It can definitely increase our numbers of the transplant. I'm going to give you an example, and this is impinging slightly on Karen's area of expertise. But let's say we've got an offer for a recipient who is a 58-year-old prisoner who's serving life sentence, who's got terminal lung cancer, and he's got metastasis, and he's got lung collapse and a recurrent pneumonia. And then the surgeon gets an offer of a donor, and the donor is in the A&E. He's got massive heart attack, and they're resuscitating from the resus, and the patient has got pulmonary edema. And the resus doctors are calling you, do you want this heart? And we are going to say, are you crazy? I mean, how can you even think of this scenario? But this was the world's first lung transplant patient scenario. So it looks crazy, isn't it, to even think of these scenario. But this is what was actually thought of at one point of time, and that's from where we are coming from. So every situation needs some imagination, and this is where the DCD heart transplant comes in. From 1968, initially there was few cases which were done in US in a very limited way, but had a massive backlash in terms of the ethical issues. Imagine a heart being allowed to stop inside someone's body and then revived so that we can use that. The entire concept is unthinkable. But a lot of research took place in Papworth in Cambridge about utilization of this heart. Although Sydney beat us to it in 2015, but in 2014, the first 3 patients were done in Sydney. But then Papworth started. They are leading the race. They're almost inching towards 100 DCD heart transplant with excellent outcomes, and we at Scotland have followed their suit and have started our DCD heart transplant program as well. And our first DCD patient has now successfully been done. But this is Papworth Hospital, where it was conceptualized, researched, and from research, it came into a clinical fruition. And this was the patient who was about to be discharged when I started my fellowship at Papworth. And I saw the results of the entire program, from the research coming into fruition into a clinical practice. So without much ado, I'm just going to take you to a journey of a retrieval. This is our team arriving at Addenbrooke's Hospital for retrieving one of the DCD heart. And I'll just let you make your own judgment. That's true. You need big lifts, a lot of logistical nightmare, and a lot of equipments to be carried. Of course, this wasn't a DCD retrieval where we were taking the heart simply. It was something called a normothermic regional perfusion, where we would put the donor on the ECMO in the center and then take the heart out. A few of the patients' reports. This is one of the patient. Day 5, he's walking around in the hospital. This is one of the DCD heart recipient. And he was so happy that Terry Tomlin raised 2,000 pounds during one of the events hosted called Chariots of Fire. And similarly, this is one of the patients who received a DCD heart transplant, and I'm going to take you or allow you to have a look at his story. But this is so inspiring because it touches. These are the patients who would not have received the heart because they were into a category where no organ would have been available. They may have lost their life, but this new technology has given them a new lease, and I'll let you go through his story.
I like motocross, the adrenaline, the speed. I like things that get the heart moving and going as such.
Tom Shing was an active, healthy teenager.
I was playing football once a week, wakeboarding the weekend, never smoked, I didn't really drink.
But aged only 19, his life was suddenly turned upside down.
I used to struggle with getting dizzy and breathing. I'd throw up. It took me 5 attempts just to get out the underground. Could do 2 stairs at a time. I would almost black out.
Tom was diagnosed with cardiomyopathy, a disease of the heart muscle. 14 years before, the same condition had killed his mum, leaving a 5-year-old Tom in the care of his grandparents.
She was sitting at the computer doing some work, and suddenly she passed out.
Tom was referred to the Royal Papworth Hospital in Cambridge, renowned around the world for pioneering the UK's first ever heart transplant. He was placed under the care of top surgeons, Drs. Stephen Large and Stephen Suey.
The thing that gets you coming to work with a spring in your step is the patients. It's a huge fillip to see them after their operation, walking the dog, doing the shopping, whatever it is.
But throughout their careers, the two Stephens have had a heartbreaking problem on their hands.
There has always been a severe shortage of donor organs. There is an ever-widening gap between demand and supply.
Tom spent 2 years on the waiting list for a new heart, and time was running out.
Every day I'd wait for the phone call. I never knew whether a heart was ever going to come up. I was getting weaker and weaker. I ended up going to the stage where I had to go and live in hospital and wait.
It was not until then that we realised that he was deteriorating. He was fragile. We just was sitting and worrying every day.
There was no ifs or buts. I would get to a point where I need the transplant or I die.
Behind the scenes, Dr. Large and Dr. Suey were working hard to increase the supply of donor hearts. At the time, transplants relied on harvesting hearts that were still beating. The medical duo's goal was to bring a heart that had stopped beating back to life.
People did say that this couldn't be done because the heart was dead, and the key thing was to show that the hearts weren't dead.
In 2015, they achieved an extraordinary breakthrough.
We can put oxygen back into these hearts that have stopped. We can put large cannulae into the big arteries and veins to put blood into the heart again. We have basically restored the heartbeat. We put it onto a machine and the heart will continue to beat. It's transported from the donor hospital and then into the recipient.
Tom was only the second person to undergo this pioneering surgery. He was in theatre for 7 hours.
Tom's operation went extremely well, and he made a very quick recovery.
Their technique allows hearts to be donated through donation after circulatory death. It means the Stephens have increased the number of available hearts by 35%.
It was a relief to me that I woke up and felt so well. If it wasn't for the team and all the pioneering work that they're doing, I wouldn't be alive today. 10 weeks after the op, I was back to wakeboarding and back to my motocross 12 weeks after. Mum would be proud, considering all the stuff that's being thrown at me. I'm going strong.
When I see Tom and hear what he's up to, you get a bit of a kick. You realise you're very lucky you're doing a job that is pretty worthwhile.
I think they're a fantastic team and we're only grateful to them. They do a great job.
I like my.
So that's about it. Thank you very much for giving me the time to talk on the elements of heart transplant. And I think one of the things that was mentioned was about the teachers. When I came to this country, I'm a relatively new addition to a consultants pool here in Glasgow. But when we talk about our teachers, there are some who are sitting here in the panel, Mr. Buchan, Mr. Zamwa, Mr. Kerr, who have taught him me immensely, and it's not just the old names that we hear about. You know, teachers do have an impact, and they can inspire you to do things and achieve them. So there's no question in my mind that we do offer excellent training to anybody who wishes to come into cardiac surgery and subspecialize or super specialize into their areas of aspirations.
Thank you so much, Mr. Doshi. There's some very insightful questions that have come through in the Q&A. A couple of students just wanting to know about the nerve innervation and how is it restored during transplantation of a heart? So
nerves are not restored back. In a way, they are cut, and that element is not coming back. But of course, what will come back is impact of the sympathetic and parasympathetic systems affecting the heart in a big way. Of course, this is something that doesn't take place once the patient is brainstem dead. Then these responses do not apply to these hearts. They behave slightly differently than the heart that we see in normal human beings. But of course, there are ways and means of knowing their functionality as well as how we can optimize their function.
Super. And then an anonymous attendee, I'm wondering if as a student, has asked, when are DCD retrievals using OCS done by anybody else other than Papworth?
So of course, the DCD program has now been rolled out nationally, and all the centers that are, in fact, the bid has been won by several centers, and the DCD program has become live. We are a part of that bid as a budding unit, so to say. We are being proctored currently. We have done our 2, and we need to do 1 more. To go into that program individually, but of course that's something which is a work in progress.
Yeah, absolutely. So it's just quite a highly specialized retrieval technique. It's quite expensive, I think, as you've shown in your video, with quite a lot of team members. So it made more sense for it to be nationally advertised and be done as teams rather than being done by each center. There's another really good question here. About how often do we manage to get, you talked about actually, you talk about a lot of visual inspection of both heart and lungs during organ donation, but one of the students wants to know about coronary angiography. Would that be of value, and is that done to donor heart, especially if they're older or if you're known to have cardiovascular risk factors? That's a great question. And what else can you use if you don't have coronary angiography to know that there's no coronary artery disease?
That's a fantastic question, and Karen, I'm sure you are aware of this. This is something that we struggle all the time, because there is a palpable disease. There's something that you can feel in the coronaries, and finally we have to abandon that heart, and we can't use the heart. In North America, they do have the facility of angioing this heart. This is something that UK is considering actively. We're not entirely sure whether we'll be able to reach there, because a lot of these hearts are being retrieved into so to say, district general hospital. But of course, this is something which is being considered. Mr. Large, Stephen Large, always used to say that when I was training at Papworth, is that we wish we have something like, he used to give a simile of a bus and a fuel. So the mitochondria, how much fuel these mitochondria have, we do not know. If they're empty, they're not going to go too far on the fuels, and we wish that there's a future where we can immediately assess an organ perfectly. Is OCS a perfect way of assessing an organ where we see the lactate extraction trend into the heart? And everybody knows that that's not the case. When the lactate extraction has reversed, and some of these hearts have been used in DCD heart transplanted at Papworth, where they work perfectly well. So, you know, one single parameter is not as effective. And some of the listeners, we hope we can inspire some of the future scientists to look into these areas where we would like to know what's a perfect organ to transplant.
Yeah, I would just back that up by saying that they're currently governed by laws about what we're able to do to donors, and it's not felt to be appropriate that coronary angiography as an invasive investigation is appropriate for that donor with respect to their family's wishes. But maybe for cardiac CT, Mr. Doshi, which I think that might be something in the future that we may be able to have within the UK, which might be useful for us. So in addition to DCD and other questions come in, are there areas of innovation that you think will further bridge the gap between cardiac donation and transplantation, so the difference between the amount of donors and what we're actually able to offer?
So one of the points that I touched upon is donor organ utilization. And as I said, we stand, if you compare internationally where UK stands in terms of kidneys and pancreas, the donor organs that are being offered to what we are using, that is almost matching to other countries for kidneys or for pancreas. For liver, there's a margin of improvement. However, for heart and lung, we can do much more. And that's something that is being actively looked at in UK currently. And they have only recently appointed something called clinical leads for donor utilization of the organs in various parts of the country. And we're trying to work with the local teams, trying to find out why that organ was not used. And similarly, are there anything that we can do to assess this organ slightly better and make sure that none of the organs which can be used are not used, so to say.
Yeah, absolutely. So there's currently 2 streams of research that NHSBT are doing, and that there's currently a clinical fellow who's looking into organ utilisation, and actually a lot of the donation process is quite heavily involved with human factors, and there's a lot of things that go on in the night of organ donation that influence the outcome as to whether or not an organ is used. That's a very heavy area of research at the minute. So following on from that, I think really quite a prudent question is how often are you up during the night, Mr. Doshi? Do you have work-life balance like all the other speakers spoke about, how important it is, and how often can you do transplants during the day, and is it a full-time job?
So far, I wish that we do have, so say for example, when I went to Toronto, when I finished my fellowship, they did 120 lung transplant. And within 2 years now, they're sitting at more than 300 lung transplant in Toronto. And speaking to them, it didn't look as if they had any issues with their family, because they would keep the lung overnight and do the transplant in the morning. And I wish we can do that. But of course, I think one of the way to look at it is, yes, you'll be up during the nights. Yes, you will be working hard, but you need to have some passion about the work that you're doing. And at the end of the day, I think the most important thing is when you go home, that tiredness will be worth, because that achievement, that sense of achievement that you've touched so many families by your work, I think that's something that you have to feel for. It's not easy for me to describe that, but that's why we all who are sitting here are doing the job. And I think I'll be wrong to say a transplant surgeon is the only one who stays awake during the night. I'm sure every one of us, whether it's a cardiac surgeon or thoracic surgeon, we all work extremely hard, and we've achieved those results for our patients. So I don't think so. My teacher always used to say, 1,000 before you will do it, 1,000 after you will do it. So there's nothing unusual that you're doing it. Better get on with it and do it. As long as you love your job, just do it. I think the family does understand that, and you have to find ways and means of pleasing the family and the wives, of course, just to make sure that they understand. But usually they are the backbones. Without them, you can't achieve your success. That's for sure.
So just to reassure those students that transplant surgery is an on-call commitment. So it's the same for all the other surgeons that are here. Everyone has an on-call commitment within their job. It's just that in addition to some of the other on-call commitments we have, transplantation is offered. So it's a 1 in 6 or usually a 1 in 7 rota. I think in Papworth it's a 1 in 5. And that means that during other times you have very little responsibilities within transplantation, but there is not enough workload to be a pure transplant surgeon. So Mr. Doshi, I'm sure you're also a cardiac surgeon in your normal working day to day, and then transplant during on call, which is the same for me, and that's the role model around the rest of the UK. That's all the Q&A for that talk. That was great. Thanks so much. I'll hand back to Farah.
Thanks very much, Karen, for handling the really fascinating questions. And I feel re-inspired. I want to be a transplant surgeon now, so it reminds me of my Papworth research day. So thank you very much for sharing that insight into transplantation.